I'm Dr. George Vetrovec, Professor Emeritus at Virginia Commonwealth University Pauli Hart Center in Richmond, Virginia, in the United States. I just gave a talk this morning regarding the use of hemodynamic support in high-risk PCI and cardiogenic shock, emphasizing the importance of defining the sweet spot, if you will, the appropriate areas in which it makes a difference. So coronary intervention has advanced significantly. First procedures were done actually 40 years ago, and I had the good fortune of being at the second Andreas Grenzig course in Zurich, Switzerland. So I've had the opportunity to watch the evolution of technology over the years. It's been a really exciting ride. Many things have been good, many things haven't turned out. And I was an early adopter of hemodynamic support, and I think it's an important addition to our armamentarium, particularly in addressing the type of patients we see today. Coronary intervention has changed significantly since the early days of performing procedures on focal, so-called hourglass lesions that were perfect, to now dealing with much more complex anatomy, higher risk patients in terms of clinical scenarios, and particularly patients who are surgical turndowns. And while we all feel good about advancing the role of PCI, the reality is the surgical turndown patients are very high risk. And this is further being complicated now because of the results of the studies that show that revascularization in patients with severe coronary disease and left ventricular dysfunction actually do better with surgical revascularization. Many of these patients, however, are turned down by surgeons, and it's both a challenge and an opportunity for interventionalists to be doing these patients. So overall, while PCI volume has decreased, the severity of disease and the complexity of the procedures has increased significantly, complicated by higher incidence of renal failure going into the procedures, worse left ventricular function, and very complex anatomy. So what are our opportunities to address this? Well, we clearly want to provide safety for the patients. We want to get them out of the lab safely. But in addition to that, if we're going to really provide optimum long-term results, which is really more important than just getting out of the lab, do we create a good scenario for the patient long-term? We have to focus on a couple of things. One is complete revascularization. All of the studies show that one of the places that PCI lags behind bypass surgery is that we don't do nearly as well at complete revascularization, and yet in those patients who get complete revascularization with PCI, they do much better. So we need to have a greater focus on that. And the second issue is the quality of the lesion treatment itself. And that's very important because the quality of that lesion treatment doesn't necessarily determine getting out of the lab, but it's very important in terms of assessing and optimizing long-term outcomes. So we really need to emphasize that. Now, the other area that I haven't touched on yet is cardiogenic shock, and unfortunately, up to now, our successes with cardiogenic shock have not been good. The mortality is still about 50%. The incidence has actually increased because many patients are now older and have been saved along the way, and now they come in with really no margin. So we're seeing more patients, older patients, sicker patients, and the mortality hasn't improved. And that's the one area of myocardial infarction that's really still a challenge. So how can hemodynamic support make a difference? And what are the best devices to use? Now, very quickly go through the devices. There are multiple devices, but if you look at intra-aortic balloon pump, Impella technology for continuous flow pumps, and for ECMO and tandem heart, in general, intra-aortic balloon pump has very limited increase in cardiac output. Yes, it increases blood pressure, and yes, we all know that we've had a save with that. But in terms of technology to improve total body perfusion, the intra-aortic balloon pump isn't the ideal device. And from a practical standpoint, with ease of use, the Impella is the most efficient for high-risk PCI and cardiogenic shock in the cath lab. And it not only increases cardiac output significantly depending upon the type of device used, it also unloads the ventricle, reducing ischemia. So in general, I think that's the gold standard today in terms of treatment with hemodynamic support. What can we expect from providing hemodynamic support? We can expect longer times to achieve better results. So it's easier to comfortably do complete revascularization. It's easier to spend the time to get maximum balloon inflation pressures, rotational atherectomy, whatever is needed to optimize lesion treatment. This is an important part of what hemodynamic support does for us. So the patients we're looking for are patients who are high risk in terms of complex anatomy, low ejection fraction, and multiple patient comorbidities such as renal failure. And the good news is recent data suggests that hemodynamic support with Impella actually does improve the outcome in patients with high risk for renal insufficiency. It's a much lower incidence if they get hemodynamic support. So what we're trying to do is optimize patient treatment. And I think the one thing that always makes me think that we need to consider hemodynamic support is when I hear someone say, and I admit I've said it too, oh, I can get in and out real quick. Unfortunately, getting in and out real quick doesn't always lead to the best results. So as I've said, complete revascularization, better lesion treatment lead to longer-term better results. Now, just a final comment about cardiogenic shock. One of the things that's become very clear about cardiogenic shock is that providing support with Impella prior to revascularization markedly improves the outcome both acute in hospital and at 30 days in those patients who get revascularized along with hemodynamic support. And now the Detroit Shock Initiative, or CSI, Cardiogenic Shock Initiative, is a very important study that is just ongoing, and the preliminary data from that has shown that compared to a baseline mortality of about 50% for these patients, patients are now leaving the hospital at a rate of about 85%. So I think we're starting to turn the corner to target these high-risk patients with hemodynamic support to improve outcomes in high-risk PCI and now in our last remaining MI challenge, cardiogenic shock. And it really makes a difference, but the important thing is selecting the correct patients.